So we are good to go. We are on live now. We can start now, sir.
You also are starting, huh? Madam, we are starting. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare journey began in 1993. We have got 25 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. We are among the largest manufacturers of ARV, APIs, and FDFs in the world, and we have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Experience Sharing program on Managing PPH, we have got Honorable Speaker Dr. Rujuta Mundadhada with us. Welcome, Madam. Dr. Rujuta Mundadhada is MBBS from GMC Nagpur, MS Obstetric Gynecology from St. GS Medical College, Mumbai and KM Hospital, Mumbai, DNB, DGO, FCPS and DMLS, Consultant Obstetrician and Gynecologist, Infertility Specialist, Director Bharati Hospital, Chandrapur, Past Vice President IMA Chandrapur, Past President JCI Chandrapur, Garima, Past Joint Secretary IMA Chandrapur, Past Treasurer and Joint Secretary Chandrapur, Obstetric Gynec Society, Past Secretary Arushi Social Works Foundation. With this brief introduction, I'll ask Madam to take over. Over to you, Madam.
Thank you, sir. So before we go for the management of postpartum hemorrhage, let us have a brief review for the postpartum hemorrhage. So next, yes. So basically, blood loss after delivery or at the time of delivery or immediately after delivery, which exceeds 500 ml more during a vaginal delivery or which exceeds more than 1 liter after a C-section is actually called PPH, but it has to be clinically assessed. If the patient is anemic, then blood loss less than this can also be defined as PPH. So PPH is common and occurs in women who are not even at risk, and PPH is the leading cause of maternal morbidity and mortality in low-income countries, and primary cause is nearly the cause of 1/4 of all the maternal deaths around the world. Next slide. So it's though it is unfortunate thing to happen, yet it is very common, mostly misdiagnosed, underdiagnosed, and then difficult to manage in poor setups where the facilities are not good. So the leading cause of maternal mortality and morbidity, MMR in developing countries was initially around 240 per 1 lakh live births, and now as compared to 16 in the developed countries, and we have to reduce this ratio as much as possible. So the global PPH incidence is around 14 million women suffer from PPH. This is what has been recorded. Off record, it could be more. The incidence of PPH is reported to as high as 2 to 4% after vaginal delivery and 6% after C-section. 38% of the maternal deaths are due to PPH. 25% of the global deaths take place in India, and 2/3 of these are attributed to PPH. So India has an unexpectedly high maternal death rate of 540 per 1 lakh live births. Next. So what is the etiology for PPH? So there are these 4 T's: tone, thrombin, trauma, and tissue. So if there is uterine atony, if there is coagulopathy, if there is trauma to the uterus, or if there is retained placenta or abnormal placentation, that may lead to postpartum hemorrhage. Next slide. So how you will diagnose a PPH patient? So presence of abdominal tenderness, secretory collapse, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, vaginal bleeding, all these are the signs and symptoms which will suggest that PPH is ongoing. So a blood loss, generally what happens with the various degrees of shock, how to assess is compensation phase, mild PPH, moderate and severe. So in compensation phase, the blood loss is around 5,000
Madam, your screen is frozen. We can't hear
Systolic
you.
BP, there will be restlessness, pallor, oliguria. In case of severe PPH, the blood loss is almost 35 to 45% of the total blood volume, which is around 2 to 3 liters. There will be again more drop in the blood systolic blood pressure, and there will be collapse, air hunger, anuria, and severe shock. Next slide. So, how do we approach the patient? Um, So we have to clinically first go for the vitals. We have to check for the pulse, blood pressure, the SpO2. Then we have to go for the abdominal palpation. Look if the uterus is tone. How is the tone of the uterus? And then we just look for the signs of trauma. If it is a vaginal delivery, look for the extension of the vaginal of the episiotomy, any vaginal tears, cervical tears. If it is a C-section, we have to look for extension of the cesarean scar, trauma to the uterine artery, or any other broad ligament hematoma that we have to assess. And if it is a retained tissue, then we have to see whether it is a retained placenta or a adherent placenta or a placenta previa, and accordingly we have to manage it. If you do not, if still we cannot find out the cause, we have to check for the coagulatory disorders like DIC or thrombocytopenia. That we'll have to check. We have to go for the investigations and then treat accordingly. Next slide. So now we have this wonderful drug in our basket of to manage PPH. So why should we choose this? Let us first study it and find out whether it's really worth trying to use this carbetocin injection for management of PPH. So carbetocin is actually a synthetic derivative of oxytocin, and oxytocin and other ergot alkaloids should be kept in the refrigerator to avoid degradation. The heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin was also to be stored in at 2 degrees to 8 degrees Celsius, and the resource poor countries could not always have the cold chain transport and storage capabilities. Hence, it was difficult to maintain carbetocin in every setup. So now, what is the change? So this new carbetocin is stable at room temperature. It need not be stored in the refrigerators. It has a good shelf life of 24 months at 30 degrees and 75% humidity. It avoids the need for the cold chain storage as well as transportation and other logistics, and is provided in a vial, uh, easy to utilize and then inject to the patient. Next slide. So we how to use this oxytocin? How to use this carbetocin? Carbetocin is to be given. Let's just first this is what use of uterotonic agent. Okay, fine. So what is the time of administration? Either you give it at the crowning of the baby's head, at the delivery of the anterior shoulder, at the end of second stage of labor, following the delivery of placenta. So it is used for prevention of PPH and active management of third stage of labor. So carbetocin usually is given as soon as the baby is delivered. We slowly inject the carbetocin IV in slow in dilution. It is to be given slow IV dilution. Next slide. So this is the chemical structure of carbetocin. As I told you earlier, it is a synthetic derivative which very much resembles oxytocin, and it is used for PPH. One vial contains 100 microgram of carbetocin in 1 ml of solution injection. It is to be diluted in 10 cc of distilled water and pushed slowly IV as soon as the baby is delivered. Next slide. So what are the clinical evidences? So these are the studies. So what is a brief description? I have already mentioned it is to be given IV slowly, and the peak in I am not able to see this slide properly. Viewers, can you change the this?
Yes, ma'am.
Is it okay?
Yeah, I think. Okay, this is oxytocin in the first column, and the second is the carbetocin. This is basically a comparison of oxytocin and
Yes.
carbetocin, right? So, storage, as we have studied, carbetocin is stable at 30 degrees, as on the other hand, oxytocin is refrigeration. IV actions of carbetocin starts immediately within 2 minutes. Oxytocin takes almost 30 minutes to be given when it is given IV. Intramuscular, it acts in 3 to 7 minutes, but for IV, it takes time. Though oxytocin effects last longer, carbetocin is uh, it lasts for almost 2 hours. Yes, next slide. So this is a trial. This is a champion trial conducted by WHO, and they've studied this drug for management of PPH. This study was conducted by the WHO people in the Department of Reproductive Health and Research. It was a double-blinded study. The objective was to compare the effectiveness and safety of the heat-stable carbetocin versus oxytocin in the prevention of PPH after vaginal birth. So almost 30,000 women across 10 countries, including India, have been enrolled for this study, and results have been documented. And what is the outcome? The proportion of the women with blood loss of at least 500 ml or the use of additional uterotonic agents. These were the criteria which they have taken into consideration, and the proportion of women with blood loss of at least 1000 ml. So this is how they try to find out how effective is the carbetocin. Yes, we'll continue the study further. So next slide. So what they studied was that these are the parameters like blood loss of more than 500 ml or the use of additional uterotonics were needed. So when carbetocin was used, the efficacy was almost good, and blood loss was comparisonly it was carbetocin and oxytocin was same. The 14.5% and 14.5% blood loss and use of additional uterotonics was required. The blood in case of more than 1000 ml, the requirement was much less, and at least side effects or adverse drug reactions effects several significantly very less. So what was the conclusion? The conclusion was that a frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was results were at par with oxytocin, and the use of additional uterotonic agents interventions to stop bleeding and the adverse effects did not differ significantly between the two groups. So if you compare, both drugs are equally good, equally efficacy is equal, and safety is same. But then why we want to say that carbetocin is better? Because it is easier to store, easy to give, and uh,
We can't hear you, madam.
and it definitely has a good plus point over the oxytocin. Right. Next slide. Can you shift to the next slide? Because am I audible?
Yes, madam, you are audible.
Okay. This is another Cochrane review study, and what they have guidelines for management of PPH prophylaxis by everyone has highlighted the WHO, the SOGS in Canada, the FIGO, as well as Germany and France. They have all carbetocin over oxytocin, and they've said carbetocin is a good to prevention as well as the management of PPH after vaginal birth and even after C-sections. So, yes, next slide.
Coming to your experience, madam, your case studies which you had given.
Yes, this is my first case, a 24-year-old primey with 38 weeks. She was in labor pains is almost 12 hours, and she delivered after oxytocin augmentation. And so let me ask you a question. If you will prefer oxytocin, if you ask me, I will say yes.
Yes.
is already exhausted, patient dehydrated and 9 kg, and as soon as she delivered, we give her carbetocin, and in slow dilution of 10 cc, wrist contracted. We could suture her episiotomy in no much time, and patient was fine. There was no PPH, and patient recovered very well, and that is how. Uh, because if patient was already exhausted, atony and all would have led to more PPH, and it would have made things more complicated. So that's why I preferred carbetocin, and it was a wonderful experience. I had another one more case, a second case. It was a case of C-section. Yes, she was a 32-year-old lady, gravid of 4, para 1, living one with 2 abortions, with 38 weeks previous LSCs, with CPD. She came in labor. Her first section was done for secondary arrest of labor, and her expected birth weight at this time was around 3 to 3.2 kg baby weight. Intra adhesions were present. The lower segment was much thinned out. She came in labor. Actually, the head was high floating, and yes, I did give carbetocin. I informed the anesthetist well in advance. As soon as the baby was delivered, the carbetocin was given by anesthetist. The uterus was very well contracted, and we could prevent PPH in this patient, because already right, because of adhesions there was some amount of oozing at the time of surgery, because we were was concerned. Plus we were worried what the placenta would be like, but then with carbetocin everything was fine. This is another case, 34-year-old elderly gravida with 36 weeks of pregnancy. She was diagnosed to have GDM. She was on not on insulin. She was on diet management. She also had sickle cell trait. She was in labor with pulse of 90, BP 130, 90. Hemoglobin was already 9.4. That was on the lower side. Blood sugars 100. She had good uterine contractions, and she delivered. She was expected a baby around 2.8, and we gave her a good trial of labor, and she delivered. Yes, before because of GDM, we suspected that there would be uterine atony, big size uterus. She was already having AS trait. Her hemoglobin is already on the lower side. So considering all these factors, we did give her carbetocin just after the baby delivered, and uterus was well contracted. And we did not give any other. We did not require any other oxytocics to her. The single dose of carbetocin was enough to keep the uterus well contracted, and we sutured the episiotomy, and patient went home happily without any more further blood loss. So that
Thank
is
you very
how.
much, madam. Thanks for your experience.
Thank you, sir.
I mean, we could really see that use of carbetocin has definitely averted some dangers.
Yes.
There's some questions, madam. What is
Yes.
the benefit of using carbetocin as a first-line drug to prevent PPH?
Benefit is, it is though I know it is a costly drug, but if you need to take more oxytocics, first thing is the blood loss is really very less. The uterus contracts very nicely. You need not give extra IV fluids, another oxytocics to add. There is no add-on cost to the
Correct.
treatment
Correct.
for
So
the
overall, the cost is not so high.
patient, because if you give one carbetocin, otherwise you give IV drip. Pardon, sir?
Overall, the cost is not very high. Overall,
Overall,
looking
the
at
cost, if you consider, actually it is not high, because if when you need to give IV fluids and other oxytocics add on, then you give misoprostol also, then you give
yes.
methadone, then you have oxytocin drip. Maintenance drip you have to keep after that,
Correct,
because you are
correct.
worried that the uterus had landed into PPH. So actually it
Correct.
is cost effective.
Cost effective.
Plus refrigeration is not required. So even in low setups where there is no refrigerator, still carbetocin can work better.
That's in fact, that's the advantage. You don't require a cold
Yes.
chain.
Yes. Yes.
With the patient profile, I mean, you have already described this high risk
Yes.
patients and diabetes. But madam, can patients with fibroid or can patients with, I mean, hypertension land into PPH?
Yes, patients with fibroids and hypertension do land up in PPH. Hypertension is known to cause PPH quite often. Fibroids may not cause, depending if it is a subsessile fibroid, it may not
Okay.
cause to that much of PPH. But if it's an intramural fibroid, or it's in the, if you are doing a C-section, it is at the lower segment where you have taken the incision, then there is a risk that it might cause more bleeding. And PIH is known to cause PPH and APH.
Anemia always remains an important cause in our country.
Yes. Anemia is almost underdiagnosed now.
Yes,
We
correct, correct,
actually
correct.
we underdiagnose it.
Even if the patient that we saw, the hemoglobin was less than 10. Then also, I say 9.4 is fairly high. There are patients with 6 and 7 hemoglobin. You must have
Yes,
seen
yes.
that.
Yes, sir. We have seen 2 gram also. We have seen
Exactly,
patients with 2 gram
exactly,
also.
exactly.
Right.
Madam, any experience of using carbetocin in retained placenta?
No, sir. No, I haven't had any such experience with retained placenta.
Okay.
Um, I don't think I have any
And
experience
in
with
case
it.
of Rh negative mothers?
Yes, yes, I have given in RH negative mothers, and I'm really, I think I am blessed now after so many years of obstetric practice that I have carbetocin in my hands,
Correct,
because these
correct.
RH negative people, they are somehow, I don't know, they are anemic also, and they are
Hmm.
somehow sensitive to PPH,
Oh,
to blood
yeah.
loss.
And then to
What
get
is the
those blood,
etiology? We don't know, but RH negative mothers are anemic and they tend to bleed more.
correct.
So with carbetocin, we can definitely avoid the PPH and the blood loss and anemia recovery, and all that is also
That's a
affected.
big boon, yeah.
Yes, yes, yes. Very nice effect.
Yeah. And in the interiors where there is no blood facility, Rh negative, suddenly going in PPH, I mean, it's a difficult situation.
Yes, sir.
Doctors generally use oxytocin for labor induction. Can they use carbetocin for prevention of PPH?
Yes, sir. I have already
Yeah,
discussed
na?
in my first
Most
case
of
that
us, yeah.
patient
In
was
fact,
having
you have
oxygen.
used, you have in your experience, you have shown that.
Yes, I am using it quite often.
Correct.
मतलब now it is a dictum कि we use carbetocin irrespective of whether the patient was into spontaneous labor or was an oxytocin drip. But after delivery, carbetocin is given, and there is a very good response. And the episiotomy is also faster, because if the
Correct,
patient keeps
correct,
on
correct.
bleeding, we keep on
Yes,
doing the
yes, yes,
massage and
yes.
packing,
Yeah,
and then
yeah,
so the
yeah.
episiotomy suturing is also fast. So
So
patient has.
it makes sense to use carbetocin as a first line in every patient for every delivery. That
Yes,
is
sir.
what you see.
Yes, it does make.
It
It
does.
does make
I
sense.
mean, little cost here and there. Overall, the cost of PPH management is fairly high. Cost of hospitalization, and
Sir,
the risk is what? The risk is finally
with
life can.
every
Yeah.
people right now having a smartphone in their hands, I
Exactly.
think this
Two,
cost
three
is
hundred doesn't
worth
make a, yeah.
taking
Absolutely,
this.
absolutely.
It
And
does
finally,
matter,
doctors
but
will
it
use it.
matters if you have to take one iron injection also for anemia correction, it will cost you
Exactly,
more than that.
exactly,
Even if you
exactly,
give one
exactly.
iron injection post delivery to correct the anemia, it will be costing you more than what carbetocin will cost.
Very correct, very correct, very correct. It's very negligible. Madam, do you generally prefer IV route or IM route?
Sir, I prefer IV route for
IV
oxytocin,
route.
carbetocin IV.
Faster of onset of action,
Yes,
obviously.
yes.
Your experience, it's well tolerated.
It's almost it's my experience is very good. I will give 10 out of 10 to
Thank
carbetocin.
you. That is very important. A drug so important as carbetocin should be well tolerated.
Yes, yes, yes.
And if carbetocin doesn't work, I mean, God forbid it shouldn't happen, but suppose it doesn't work, what would you use?
If it doesn't work, then we do consider giving oxytocin 10 units intramuscular. Then
Uh,
we start the drip. When we give misoprostol also per rectum 600 mg.
everything, everything,
Written everything
everything.
is there,
Yes,
but
yes, yes.
it is like maybe once in 2 months or 3 months such things happen.
Acha, you have experienced such ones.
In a patient,
It
if I
is bound to
deliver
happen. Yeah,
almost
yeah.
if I
It's bound
deliver
to
one patient per day also, then the chances of having such need is very very less,
yeah,
because we everyone in the staff has been trained so nicely when to give carbetocin. So if the
absolutely.
timing is perfect, then usually we don't require to give another oxytocin.
That's the credit of gynecologists, madam, to train the staff, and they are so well versed. In fact, someone else
Everyone
very
has to
well.
be trained.
Yeah, during
Labor
the
patients are not managed by
absolutely.
doctors. It is a
Yeah,
team,
yeah,
the
yeah, it's a
staff, and
team.
everyone.
In fact, in one of the webinar, when gynecologist told us, I asked the question, the next question that what's the role of anesthetist? The gynecologist told me our understanding is so much that when I look at the anesthetist, he knows what to do. I mean, that is the understanding.
Yes,
That's a
yes, yes,
teamwork.
yes. We have that team
Yeah,
coordination.
exactly. And what's the advantage of carbetocin? Well, as you have already answered this, I want to know.
Yes,
Should it be kept as a reserve drug? No, we have discussed this, and it should be a first
first
line.
line,
Yeah.
first line, first line.
So overall, to give take-home message to the audience, apart
My take
from
home, yes, sir,
yes,
yes, sir. My take home message is you train your staff how to use carbetocin. Start using carbetocin, just as all obstetricians love oxytocin, they will love carbetocin also,
absolutely.
because just as oxytocin helps you to deliver the patients who are not going into active labor, and you with oxytocin they go into labor and they deliver vaginally, and you feel so obliged ki, thank God she's delivered, she did not require a C-section. In the
Correct.
same way, carbetocin will give you such a good satisfaction that this patient did not
To every patient in every delivery.
land up in PPH.
Yeah.
There was no excessive bleeding. Patient
That's
is
what
not
it is. Yeah.
anemic, and you could suture the episode from the labor room. So it in women, and definitely this will and our research, the MMR will really reduce if we use it
Very
very
good. Very good.
efficiently and more, and we train our each and every staff to how to use that drug.
Thanks for sharing your experience, madam. It was really wonderful because our doctors want these type of experience more than the clinical trial papers. This will give them confidence. The way you have explained and your own experience will give them, I'm sure, very large confidence to use this drug. Thank you very much. Thanks for taking time
Thank you,
to
sir. Thank you,
handle
sir.
this. And thanks all the doctors who took time from their busy afternoon schedule and attended this, because we know gynecologist time is always busy. Expect unexpected delivery can come anytime. And thanks marketing sales team of Hitro. Thanks Bivas. Thanks Bhuvan. Thank you so much. You can log out, madam. Thank you so much. Wish you a very pleasant afternoon and a very pleasant day. Thank you. Thanks, Bivas.
Thank you, sir. Thank you, sir.